Good morning, everyone. It is my distinct pleasure to welcome our esteemed speaker, Dr. Vykunta Raju, Professor and Head of Pediatric Neurology at Indira Gandhi Institute of Child Health, Bangalore. Dr. Vykunta Raju is an accomplished clinician and an academician, having completed his DM in Pediatric Neurology from AIIMS, New Delhi. His contributions to the field are truly remarkable, with over 250 plus PubMed indexed publications and more than 100 others in additional peer reviewed articles. Numerous research projects to his credit. He's also the author of a textbook on cerebral palsy and has contributed over 30 chapters to leading textbooks. Given Sir's vast experience in pediatric neurology and genetics, we are honored to have him guide us today on a topic of immense clinical relevance: selection of genetic test. On behalf of the participants, I extend a very warm welcome to you, sir, and thank you for taking the time for sharing your insights with us here today. Over to you, sir.
Thank you. The outset, I thanks organizers Lifestyle for giving the opportunity to speak on this subject. My slides are visible.
Yes, sir.
Okay, shall I start?
Yes, absolutely, please.
Yeah. So today I'll be talking about what test should be selected and why it is important. As you know, nowadays the genetic test is commonly done test as a first line drug, a first line test because of easy availability and affordability. The selection of test is very important. To select the appropriate test, the clinical diagnosis and differential diagnosis also plays an important role. So I'll be talking basically clinically oriented phenotyping, why it is important to select the test. So basically, I will approaching the various clinical scenarios based on how they will present to clinicians. Most common presentation is developmental issues like developmental ADHD, autism. And second common thing is neurometabolic disorder with recurrent encephalopathies, recurrent family histories, and also like CP mimics. And epilepsy is also one of the other commonly seen
Uh,
condition where genetic plays an important role.
Doctor,
And
I'm so sorry
the
to
last,
intervene, but the slides are not visible. So it's only the screen with the smaller
okay,
tab. So I think you have to share the entire screen so that when the slides change, then we can see it.
I will reshare once more.
Yes, sir.
Now,
I
are they
the first slide is visible, sir. Yes, yes, visible.
now?
Yes, visible, sir.
Shall I go ahead?
Yes, yes, please.
So I'll be talking based on how the child comes to clinicians based on various phenotype they will present. As I told, it can present clinically with the developmental issues or epilepsy or neuromuscular problems. So I'll be talking about some of the case scenarios, how selection of test is very important. So why genetic test is important, as most of you know, that just a repetition. So the basically these tests are helpful to select especially the exact treatment because many of them are treatable nowadays, especially with the precision medicine. Many of them like neurometabolic and epilepsy conditions also. Not only the treatment and diagnosis, but it also gives that the importance of genetic counseling also very important, and the long-term prognosis also to take care of further steps in the management. So as you know, the NGS is a most commonly used test nowadays, and definitely it has helped in discovery of many of the disease-causing genes, and also to understand proper molecular genetic mechanism of various genetic disorders, especially in pediatrics and neurology also. So earlier days, it was thought that genetic test is an expensive test and it should be a last resort. But now it is known that many of us that it is an inexpensive and rapid first aid test, as it is easily available and not very expensive test compared to other tests currently available for investigation. This is just a brief history. As you know, earlier on the various evolution of genetic tests from karyotyping to whole genome sequencing. I will not be going to details. So basically two types of genetic test. One is a cytogenetic, one is molecular genetics. Cytogenetic basically karyotyping and microarray. Still there is some value of these tests. I'll be telling where exactly it is useful nowadays, and molecular genetics I'll be telling in detail. So these are various broad tests still is very important to select the drug to get the better yield. So microarray is still a useful test, especially if you are thinking of multiple congenital anomalies, dysmorphic features, and developmental delay. And next, the single gene test nowadays is rarely used because panels, unless if you're thinking of specific disorder, very narrow diagnosis, otherwise panel tests now less commonly used in the availability of PC level whole exome, whole genome sequencing. And repeat expansion is still commonly used in neurology, especially some of the disorder like Fragile X syndrome and also the triple myotonic dystrophies. These are commonly used if you are thinking directly for triple repeats disorder. And as you know, the today's first choice is an NGS based test, whether it is in a whole genome or gene panel or whole exome sequencing or clinical exome, various names are given. But NGS is currently available best tool to diagnose various neurological disorders. This is a test given in the most of the tests. I will not be going to details. Karyotyping is still a role, especially if you are thinking of translocations. That is more main major role. And fish test, especially if you are know that the disease, what the disorder you are thinking, like Williams syndrome or Prader-Willi syndrome, we can go directly. Micro also, as you told, it is very useful test if you are not able to get any specific diagnosis and we are thinking of large deletion, we can go for microarray. Whole exome, it is a test of choice. So the because especially if you think of single gene disorders, the yield is very high. Again, this is a table showing the various NGS-based tests, single gene versus gene panel versus whole exome. Currently, the whole exome is a better choice, and if it available and affordable, whole genome also better choice compared to going for single gene and gene panel because a lot of limitation, you can miss many of the disorders. So this is a test where MLPA is still a major role when you are thinking of neurological disorder, especially if you are thinking of disorder with a large deletion, where the NGS can miss, like whole exome can miss some of the disorders. So still there is a lot of role for a neurologist or a pediatrician. If you are thinking clinically or diagnosed like a spinal muscular atrophy, better to go for MLPA rather than going for whole exome sequencing. Similarly, like Duchenne's muscular dystrophy and sometimes Rett syndrome and also erythromotor HMSN. If you are thinking, you can go directly for MLPA. Especially, it is very applicable for SMA and DMD, rarely for other three disorders. So even though the easily available whole exam, but only in confusion conditions, you can go for whole exam. Otherwise, if you are strongly thinking SMA, you can go for directly for MLPA rather than going for whole exam sequencing. As you told, repeat expansion disorders are commonly present in neurologists. So this is a list of disorders. If you are considering the clinically, these are the disorders, better to go for triple repeats. So instead of going for whole exam, where it can miss the disorders. Most common in pediatric neurology is Fragile X syndrome, Friedreich's ataxia, myotonic dystrophies, and some rarely you will see the spinocerebellar ataxias. So as a part of clinician, the phenotyping is very important to select the appropriate test. I'll be giving some of the examples based on various systems involved. As you know, pediatricians or pediatric neurologists commonly seen children with presenting with developmental delay or intellectual disability or various other developmental problems like autism spectrum disorder, ADHD. So as you know, this clinical diagnosis can be made with looking at the child like this is a classical feature of Down syndrome. If it is there, you can go directly for karyotyping instead of going for any other test. Even if you advise whole exam, it can miss. So if you are sure that it is Down syndrome, you can go for karyotyping rather than going for other tests. Other phenotype, in addition to development delay, there are a lot of artistic features or any female child with microcephaly, with acquired microcephaly with midline stereotypies, you should always think of Rett syndrome. We can go for MLPA for Rett syndrome. The other children, similarly with developmental delay, with artistic feature, with epipopate like appearance, excessive smiling, with this phenotype is there, you can go directly for testing for Angelman syndrome rather than going for whole exome, whole genome sequencing, where it is yield is very high. Similarly, in the boys with intellectual disability with classical features of Fragile X syndrome like large head, prognotism, large nose, and large testes, with artistic feature, it should better to go for triple repeats as I told for a Fragile X syndrome rather than going for whole exome sequencing. With some of the other children with classical features of dysmorphic features suggestive of Fragile X syndrome. So whenever a child present with a developmental with artistic feature with ADHD and male children, you should always consider Fragile X syndrome where specific tests should be ordered. Similarly, the other developmental disorders is initially it's a floppy baby, newborn baby with a lot of feeding problem data with excessive weight gain, short stature with dysmorphic features like obesity and almond-shaped eyes, short stature, artistic feature. You should always consider Prader-Willi syndrome as a diagnosis, and you can go specific test for Prader-Willi syndrome rather than going for whole exome sequencing. Again, the same other photograph showing the same excessive obesity and intellectual disability and artistic features. And some rare disorder, but difficult to diagnose if you are aware that it is easy to diagnose. Again, the intellectual disability with characteristic Kelvin Pacey with sometimes they can come with cardiological problem with aortic stenosis, pulmonary stenosis, hypercalcemia. You should go for microarray fish for Williams syndrome. So that gives important clue. And sometimes may not be available the specific test if any child with characteristic faces with intellectual disability, like this child is large at large per gestational age with family history of similar parents affected, they can go directly, can consider like Soto syndrome. This characteristic can go for whole exome sequencing in these children. So this is a brief chart recently updated. So whenever child with developmental delay comes, should always exclude acquired causes. After excluding acquired causes, you can consider the genetic testing. So genetic testing, as I told, so based on the clinical phenotype, you can decide. So if it is you are thinking of specific etiology, as I told, like autism or Angelman syndrome, Prader-Willi syndrome, we can go for directly the specific testing. If it is not clear, you can go for whole exome sequencing with copy number variation or whole genome sequencing based on availability and affordability. So that yield will be very high instead of going for children with whole exome sequencing. Coming to next group of categories is the neurometabolic disorders. There are various neurometabolic disorders that are very important to diagnose very early because to start treatment early and to get the proper treatment response and the good response for the treatment and also preventing the family people with recurrence of similar disorder. This diagnosis is very important as know that many of them are treatable not only fully but at least partially can be treatable. So earlier days, the most commonly used test was the routine test like metabolic screening. After failure of TMS, the GCMS usually used to go for expensive enzyme test where the reliability and reproducibility is very less and also the yield will be very less and availability also an issue where we used to go directly for invasive testing like muscle biopsy, nerve biopsy, skin biopsy. But with advent of NGS, so after the first metabolic screening, you can go directly for whole exome sequencing rather than going for invasive testing. Invasive testing can be considered if there is not able to diagnose whole exome. If the VS is there, then if you are strongly thinking of this specific condition despite whole exome negative, then you can go for invasive test. So this NGS replaces invasive test currently with easily availability and affordability also. See some of the case scenarios how the treatment, how genetic testing modified the treatment in current era. So this is a child came with the developmental delay. Earlier, in addition to developmental delay, child has an involuntary movement and extrapyramidal symptoms and ataxia. And also these movements are misinterpreted as a seizure and treated with multiple anti-seizure medication without any much benefit. And an examination, there was a microcephaly, and this is a video. You can see that this child has ataxia and dyskinetic, a dyskinetic movement. Also, this child has treated with multiple anti-seizure medication without much benefit. So initially thought of differential disconnect cerebral palsy or deferred responsive dystonia or rare possibility of metabolic condition including organic acidity or mitochondrial disorders. So this child investigated. So the routine EG was normal, hence all anti-seizure medication are discontinued, and MRI also normal, and routine metabolic screening was normal. So at this stage where the special metabolic state TMS was done, it is showing the phenylalanine was high, but the level was only around 300, not usually like a classical PK you will get more than 1000, but in this child it is showing only around hundreds only, and there was elevation of phenylalanine to tyrosine ratio. So in this setup. The further testing, like other classical testing for hyperphenylalemia is various other metabolic tests like taurine levels and CSF neurotransmitter estimations. Usually, the availability currently in Indian setup is less commonly available and very difficult to transport. Yield also will be less. And this is a condition where a genetic like NGS plays an important role for diagnose these children because many of them are treatable with simple medications that are available in Indian setup also. So as the slide shows, there are various defects in the neurotransmitter defect can cause increased phenylalanine in addition to PKU. So where the management gives an important benefit for the child and also family also. So this child has increased phenylalanine was there. So hence it thought of consider neurotransmitter disorders. So hence its child started with simple dopa medicines, L-dopa and carbidopa combination. Child noticed significant improvement with dyskinesia and also ataxia. So you can see the child within few days of starting the medicine, child has a significant improvement with ataxia. And during follow-up, almost 10, 15 years, child has a significant improvement and improved significantly. So this is a flow chart showing that whenever child comes with developmental dyskinesia with the increased phenylalanine, usually classical PK is very easy to diagnose because classical features of microcephaly, hypopigmented hair, and serum phenylalanine will be more than 1200. But these features were not there. In non-classical features, the diagnosis is important, but the specific diagnosis takes time, and the management also differs based on various subcategories. So this is a table showing how to differentiate classical PK versus tetrabiopterin defects. Usually in PK, as I told, classical features of GDD, microcephaly, autism, and infantile spasms are very common. But in tetrahydrobiopterin defects, usually there will be extrapyramidal symptoms are very common. Hypopigmented hair is not very common. Maybe mild hypopigmented hair can be there, and they can have a normal imaging. So the diagnosis further requires further metabolic tests I told in the CSF test. And this is a various tests and various neurotransmitters we should consider for testing like neopterin, biopterin, taurine levels in the urine, but they are not currently available to differentiate each subcategories. Where NGS plays an important role. So this is a classical PQ. You can see these are very important, but easy to diagnose because of patient's increased phenylalanine and classical clinical phenotype of hyperpigmented hair and epilepsy, refractory, and increased phenylalanine more than 1000. So when there is a borderline cases like phenylalanine less and lot of other dyskinetic movement are there, you will consider tetrabiopterin defects. So these are flow charts, how it is useful. But despite that, usually the confirmatory test is currently the NGS-based whole exome sequencing that gives specific diagnosis. So the important message from this case is all involuntary movements are not seizures, so you should not be treated as seizures. So clinically mimicking disconnects CP with normal MRI and normal birth history, you should always investigate for further metabolic conditions. So increased phenylalanine not always due to PK. You should consider other tetrahydrobiopterin defect because they are have a specific treatment modality compared to the regular diet control itself. So this child basically suffering from DHR deficiency and child is treated with simple L-DOPA and child has significant improvement. So various other neurotransmitter disorder that can be easily treatable. These are some of the important neurotransmitter disorders where the NGS plays an important role compared to any other metabolic disorder. You can see this child is present from infancy. Child is almost significant developmental delay, and child has improved over a period of 2 3 years. This child basically a neurotransmitter disorder because of septopteron defect. So child is diagnosed basically based on NGS based diagnosis, and child has a significant improvement. So similarly, the GTPS, other neurotransmitter disorder, this child also earlier diagnosed with encephalitis sequelae. The child has significantly improved with treatment, and child is ambulatory. So this child again increased phenylalanine in the range of 300 or 400, but child has improved significantly with simple L-DOPA medicine. So various other neurotransmitter disorder where plays an important role. Yes. So again, this child is a tyrosine hydroxylase deficiency. Earlier days, it will be easy to difficult to diagnose these children, but now because other than NGS, currently available neurotransmitter estimation is not available, so difficult to diagnose. So with specific diagnosis with NGS based diagnosis, children are only on Syndopa that are currently available. Children are significant improvement. This one more child late onset, you can see child has almost severe disability, and within few weeks of starting treatment, you can see the significant improvement. So the neurotransmitter disorders in specific compared to other neurometabolic disorders, where the NGS plays an important role because of easy to diagnose and various other metabolic tests currently not available in Indian setup, and treatment also very effective compared to other other neurometabolic disorder. You should always be consider this test as an important tool for diagnosis of these children. Coming to next group of disorder that is commonly seen in pediatrics and neurology is an epilepsy. As you know, epilepsy has a various causes. Genetic and metabolic etiology is one of the important cause where a specific diagnosis is important because they can present with a refractory epilepsy without much significant response for routinely available anti-seizure medication. So where the when you're thinking of any refractory epilepsy, especially in the newborn and especially early part of the infancy where the cause is not clear, you should always consider the genetic etiology, and you should always consider possibility of testing whole exome or whole genome for a specific diagnosis. As you know, various genetic epilepsies are discovered from ranging from Dravet syndrome initially to many other precision medicine currently available for various epilepsy syndromes and also various epileptic mutation causing epilepsy in children. So evaluation of clinically very important. So after excluding acquired causes and you are strongly thinking of genetic condition, you should always consider the possibility of this genetic etiology as a cause for epilepsy. So the role of genetic diagnosis is very important, not only in the refractory epilepsy, even in self-limiting epilepsy is also very important. I'll be giving some of the case scenarios. Coming to the most commonly faced problem is especially newborn babies with refractory seizures. So when they comes with especially the newborn baby with refractory epilepsy not responding routinely with the currently available medication, you should always consider possibilities of the vitamin responsive disorders, especially pyridoxine, pyridoxyl phosphate. So these are two case scenarios. They can present a similar phenotype, but genotype is different and outcome also different. So both of them children present the early part of the newborn period with refractory seizures with myoclonic epilepsy, and routine test was normal and EEG almost showing birth suppression pattern. So one case turned out to be an NCH and other turned out to be a PDE, pyridoxine dependent epilepsy. So based on genetic tests, you are able to differentiate. Even though metabolic tests are available, they are expensive and reliability also very poor. And it is invasive like CSF testing for lysine and transmitter levels for PDA. But the genetic tests finally confirm these children are different etiology. As you know, the PDA is a simple treatment and easy to give like pyridoxine, but they will respond very well with pyridoxine. But NKH is a long-term prognosis not so good. So NGS the exome sequence played an important role in this group of disorder to diagnose exactly what is the cause for especially the early part of refractory epilepsy in newborn period and also infancy. So these are various children treated for many months with many anti-seizure medication, including some of them present refractory, super refractory status epilepticus, not responding for currently available anti-seizure medication, but all are turned out to be in a pyridoxine dependency epilepsy. So So these children, any children with refractory epilepsy with the routine available test is negative, we should always consider pyridoxine deficiency. The response rate is very good, even though they can have some minimal disability and developmental problem, but the epilepsy outcome is many of them, our series, they improved very well with just supplement with pyridoxine dependency. So that is an importance of testing, genetic testing, especially in epilepsy cases. You can have a specific diagnosis and specific treatment, and you can give proper prognosis for the family, and also you can confidently give the long-term outcome for the family also. Not only these vitamin responsive, some of the mutations like channelopathies, you can give some important, whether it is a gain of mutation, loss of mutation, where precision medicine is an important like gain of mutation, you can consider sodium channel blocker. If loss of mutation, you should consider like other DE, where treatment is differs. So sometimes you will also face like HI like phenotype. If MRI showing like HI, like this MRI showing, you can consider refractory epilepsy early part of the newborn admission, but MRI showing HI, but clinically no HI. So genetic test gives important in that category. Most common is molybdenum cofactor deficiency or sulfate oxidase deficiency. Diagnosis is very important because the treatment and outcome is differs compared to the HI, normal HI. So these are various list. I'm not going to details. Various currently available genes where diagnosis plays an important role for selection of anti-seizure medication, from ranging from vitamin responsive epilepsies to channelopathies and some of the epileptic encephalopathies. Based on the genetic diagnosis, you can consider various specific treatments from ranging from vitamin supplements to and also diet to gene therapy also. So the specific diagnosis is an important part of the proper prognosis, and also to get the new treatments may come in the future also. So not only the treatment, but it can sometimes useful for pharmacogenomic response also. So you can avoid some of the drugs like HLA if it is there, you can avoid some of the drugs that can worsen the drug reactions. Some of the self-limiting epilepsy has a role of genetic testing. So so genetic testing is important focal epilepsy, especially in infancy, because these children they come with a cluster of seizures. So where sometimes he should have been investigated extensively with neuroimaging and other metabolic tests. So simple, the whole exam gives some of the clue for diagnosis of these conditions like channelopathies and PRR2 mutation. These are two conditions where the self-limiting epilepsy, so that you can decide the drug of choice like sodium channel blockers, and you can avoid unnecessary investigation, and continuing the long-term medication may not require. You can taper and stop as early as possible, maybe after 1 or 2 years maximum. So no need to continue long term, and it gives satisfaction that you are diagnosed specific condition. Long term outcome prognosis also can be given to the family, even though it is a self-limiting condition. Coming to the last category, neuromuscular disorders, yeah, also an important category of disorders where genetic testing plays an important role. So this is the children, as I told, the diagnosis of SMA is very important because the test fusion in SMA is MLPA rather than whole exome sequences. So various subcategory of SMA, you can see the classical bell-shaped test and bright child with hypotonia and uh, laxity, and these other children you can see mini polymyoclonus, tongue fasciculations. So these signs are important to suspect SMA, and you can see the fasciculation. So clinical diagnosis is very important, especially the SMA type 3 is very difficult to diagnose. SMA 1 and 2 is very easy to diagnose, but type 3 can be mistaken for various other neuromuscular disorders. So mini polymyoclonus is one of the features that helps in diagnosing these children. So the specific test like MLPA should be ordered rather than NGS, where clinician plays an important role for selecting the test. Because SMA is nowadays it is treatable, and medications are also easily available. Specific diagnosis very important for this family. Next group of disorder in neuromuscular is an DMD, as you know. So DMD can be confused with various other neuromuscular disorders like LGMD and myotonic dystrophy, but clinical features gives an important clue where the selection of tests like MLPA is very important. As you know, that phenotype can be seen in many other disorders. So as you know, the so Gower sign is the one of the tests that is commonly seen, but Gower sign does not mean always DMD. You can see various other female children, various other, one child is a congenital myasthenia, other is a limb-girdle type of myasthenia, myotonic dystrophy. So many of disorders can present to Gower sign positive and proximal weakness. So it does not mean always Gower DMD. So other features like Pallis sign, classical presentation, natural course of the disease are also important to suspect DMD and to get the specific test like MLPA initially instead of going for other tests. One more commonly faced floppy infants or in the newborn period also one of the last case I'll be discussing. This child present initially with day one with like birth asphyxia features, child is requiring prolonged ventilatory and prolonged breathing problems. So whenever child with birth asphyxia comes to newborn in ICU, so most of the times we'll consider birth asphyxia as the reason, but some of the rare phenotype in the children you should suspect like this child is even though birth asphyxia, but child has never had a conversion, but child is requiring prolonged breathing and also the feeding issues are the main issues. So where you should consider other rare possibility of neuromuscular disorders also. Even though child is a birth asphyxia, baby not cry, but baby has never had a seizure in this child, but child requiring prolonged respiratory care, requiring tracheostomy and prolonged feeding issue, requiring NG tube and the gastrostomy feeding also. And an examination, otherwise child was bright, no seizures, but there is, you can see that child is a floppy. And this child, other history is an important family history. This child, you can see in the family, lot of parents and grandparents, grandmothers also affected. It's a classical motor weakness. And this is a family, you can see the looking the mother, you can see the lower facial weakness. And mother is also myotonia. So this child is a myotonic dystrophy. So the examination for parents and also family history gives important clue in this child. It is a myotonic dystrophy present with a prolonged feeding and breathing problem. Initially diagnosed as birth asphyxia child. So this child, the clinical examination, like appearance, the face, like inverted V-shaped upper lip, and also the undescended testis also was there in this child, and CTV also was there, and like floppy, peripheral floppy child, like appearance, this you can see. So this examination gives and family gives an important clue for diagnosing this children, this child. So to summary of this case, the family history is very important. Examination of parents are also important. Some atypical features in case of HIE you should always consider other rare possibility because the diagnosis is different and specific treatment is different. So this child initially, as I told, genetic cause is considered, but they are sent the whole exome sequencing instead of sending a specific triple repeats. This child has all investigation. I'm not into details of investigation because of lack of time. So this child initially diagnosed a neuromuscular problem. They sent an whole exome sequencing, but it is showing various of unknown gene, but not related to phenotype. Hence, the specific like triple repeats has sent, it has come positive. The child has finally diagnosed congenital myotonic dystrophy and child started in carbamazepine. The child is a significant improvement and mother also started, mother also noted improvement. This is a chart showing various clinical features for a floppy infant that gives important clue for the diagnosis. The myotonic dystrophy is the one, and I also told the spinal muscular atrophy fasciculation is an important care. Prader-Willi, as I told, they can present initially as a floppy newborn baby. Later only they can develop excessive weight gain, other things. So that clinical clues gives important clue for the diagnosis because the testing for each disease is different rather than going for whole exam sequencing because SMA is MLPA, concomitant dystrophy or triple repeats and probably need to select a fish or other tests. So instead of going for all children with whole exam sequencing. This is same in the flow chart. So other in the older people, myotonic dystrophy, they can present lower part of the facial involvements. As it is, no anticipation is common in these children. So children will present will more severely affected, and you are diagnosed most of the times in the mothers after diagnosing the child. So family examination gives an important clue. So to conclude from talk, so the NG is an important test that is currently available. So it gives an important role for diagnosis, and also precise therapy can be selected, and it avoids many of the invasive tests earlier used to be done earlier, so that can be avoided, and the cost also it is helpful, and it also important not only for the precision medicine and also genetic counseling. So as you know that phenotyping is very important to select the type of the test, even though whole exam is a commonly used test, and it can time miss many of the disorders unless if you ask for specific test. So the diagnosis is very important because of currently available medicines for specific disorders with specific precision medicine, or also in the future they may get the good treatment also in the many of the disorders, including gene therapy of many of the currently non-available treatments. Thank you.
Thank you so much, sir, for that insightful session. I would now open up the platform for any sort of questions. Please drop your questions in the chat box and I'll pick them one by one. So, sir, one of the first questions that come up is how do we choose the right test to rule out developmental disorders?
Yeah, developmental disorder initially you should rule out most common in Indian setup is still the acquired causal like cerebral palsy or meningitis E. coli or intrauterine infections. So by clinical examination, will give some clue that whether the child is suffering from acquired or the genetic causes, including the family history, detailed birth history should be taken. So after ruling out acquired causes, so you should phenotype the child, whether the child is an only the global developmental delay is there or motor delay is there, or with the features of autism, or as I told, some features like dysmorphic feature list suggestive Down syndrome or Williams syndrome, Prader-Willi syndrome. If a specific diagnosis is very clear based in clinical phenotype, we can go for directly the testing for similar disorders. If it is not there after ruling out acquired causes, you can go for whole exome sequencing or whole genome sequencing if the affordability is not an issue. So that is the way usually currently with especially you should ask for copy number variation. Most of the tests nowadays whole exome they will do copy number variation simultaneously. So it is.
So the second question is, are there different tests to detect triple repeat other than MLPA, like PCR or RFLP?
So the triple repeats test they mean they are asking what are the tests currently available to triple repeats?
Yes, sir.
Triple repeats PCR usually commonly used, but nowadays the whole genome techniques also instead of going for triple repeats, they may pick up in the whole genome sequencing also triple repeats sometimes. PCR also it will detect.
So the next question is, in children with early onset epilepsy or epileptic encephalopathy, how do we decide between an epilepsy panel or a whole exome sequencing?
As you know, epilepsy panel earlier used to do epilepsy panel because epilepsy in the newborn babies ranges from not only epilepsy gene, it can vary from neurometabolic disorder, vitamin responsive disorders, various other disorders. So if it is available, because the cost is not a factor, whole exome versus gene panel, the cost will be same only. If you are not sure about what exactly the gene you are thinking, you can go for whole exome sequencing only rather than going for gene panel, because gene panel based on which country or on where which lab they are doing, they may not include all genes because the epilepsy, not only the because of epilepsy genes alone, the many of the neurometabolic disorders can present epilepsy in newborn period. So better to go for whole exome you are considering, and you can ask clinical details can be given that you are thinking about exactly the disorder, so they can see. So instead of gene panel, you can go directly for whole exome. Sometimes in the whole exome may miss where maybe some advantage gene panel, they may look for specific genes. That is the only advantage. But if you are asked for specific gene clinically or specific condition, whole exome is preferable.
Okay. So the next question is for, I think, married couples, whole exome is better or Sanger variants are better? I think the
So
question is
if
for
the
carrier.
index case is affected and you can go for Sanger sequencing is a better choice. So if you have a lot of other variants in the index case and a lot of consanguineous marriages or other members also affected with different disorders, so you can go because whole exome also. But otherwise, if it is specific test, Sanger is better because whole exome can cause a lot of confusion because it may many other genes, lot of ethical issues. But currently, the index case can be tested, like Sanger sequencing for specific mutation can be tested.
Got it. So the next question is, why is NGS not preferred for conditions like Fragile X and SMA? Won't it be able to pick up more than 98% of cases, as currently some NGS covers CNVs also? What exact mutations can be missed by NGS?
NGS large deletion duplication can be missed because the SMN and the DMD is a large deletion that can be missed even though it detects some of the but the large deletion can be missed. So that is the only reason why the MLPA is used instead of going for whole exam. If you are not sure, if you are thinking of SMA versus other neuromuscular disorder, you can go for a whole exome sequencing. But you are sure that it is an SMA only based in clinical phenotype, going for MLPA is better because whole exome, even though it can pick up the gene, but it can miss sometimes.
So the next question is, if we have a clear history of HIE causing CP, should we still do a genetic test?
Yeah, there is currently the guidelines for testing cerebral palsy in children. So even though you thought consider the cerebral palsy, like if the clinical examination, classical history is there, and the imaging is confirmatory of the specific cerebral palsy, then no need of testing the genetic problem. But the MRI classification recently is given. It is very useful test, useful diagnosis where genetic test is indicated in case of cerebral palsy. Like MRI is normal and it is not correlating clinical phenotype and it is the imaging features are not considered cerebral palsy or extra features are there where we can consider the genetic testing. But if it is a clear-cut clinical radiological association is consistent, no need of doing for genetic testing. Otherwise, in doubtful cases, you can go for genetic testing.
So the last question, in mosaicism disorders, what sample should be taken and is genetic testing useful?
No, that depends on where these are. Usually, the fibroblasts are better. The yield is better rather than the whole blood because it can miss the disorder, especially what you are looking. So, fibroblasts are better.
Oh,
And
great.
where exactly the tissue you are suspecting, the tissue sampling also better.
Okay. Okay. Great. Thank you so much, sir, for your time and for the beautiful session. I'm sure that all of us here today learned a little bit more, and especially with the segmentized way that you have given us the presentation and also with the case-based discussion. I think a lot of questions that are currently burning topics in terms of pediatric, clinical concerns. A lot of people have gained a lot of knowledge today. So I thank you once again, sir.
Thank you.
I would request Rajesh to say a few words.
Yeah, hi, good morning to you, Dr. Raju. Thank you so much for giving us an opportunity to be part of this program, sir. We would love to do more such programs, interactive sessions with
Thank you.
experts like you. Thank you.
Thank you so much, sir. And thank you
Thank you.
everybody in the esteemed guest list for giving us your time as well. We will be circulating a thank you mail as well as a feedback form. Please feel free to write to us with regards to any future topics that you would want us to conduct webinars and masterclasses on. And thank you so much for all your support and being with us.